started and started your timer, and here is your question. Once you have read this, please tell me there is something written on the next page as well.
All right, ma'am.
Yes, so there is just little bit here, just a question.
Okay, so for the management of this patient,
right now, so if you have read and understood, considering the critical care scenario, kindly begin.
okay, so first of all,
yes.
I will begin with the care of critically ill surgical patient algorithm principle by assessment management of the airway, breathing, circulation, disability, and exposure of the patient.
Yes.
And then after that, I will for this patient this patient is obese and in discomfort. I will first of all I will pass this CVP line and start the fluid rehydration and monitoring of this patient. And after that, I will give painkiller according to analgesic ladder. And most likely, I can give the pethidine or meperidine. And if not pain resolved by that, I will start with the analgesic ladder and will move upward in a stepwise fashion. And I will also take the blood sample for arterial blood gases, full blood count.
Can you please tell me where do you plan to manage this patient?
I will immediately contact the ICU bed manager and request for a bed and will transfer the patient to the ICU.
Okay, who would you involve in the management of this patient?
For the management of this patient, I will involve the dietitian and my senior surgeon, general surgeon, and
considering this scenario, kindly tell me what are the differential diagnoses that you will consider in your management?
Differential would be for this patient acute relapsing pancreatitis, pancreatic pseudocyst, and acute cholecystitis, ascending cholangitis, perforated ulcer.
Can you please tell me why this patient is tachypnic?
This patient is tachypnic because of the pseudocyst mainly.
Can you explain the mechanism? How is it causing pressure?
Sorry,
can you explain the mechanism, how this tachypnea is taking place? So there is abdominal pain, which is stimulating, which is
causing increased respiratory rate, and there is pseudocyst, which is causing the pressure and increasing the respiratory pressure over the lungs and increasing the respiratory rate, and also due to the sympathetic overdrive.
Yes, sympathetic overdrive. Yes. All right. Okay. So in order to rule out your differential diagnosis, what are the investigations you would ask for?
Okay, first of all, I will do the blood investigation, and after that, I will go for the radiological investigation, starting with the ultrasound of the upper abdomen, axial computed tomograph of the upper abdomen, and then if I don't find any significant findings, and if there is risk or suspicious of cholangitis or gallstone pancreatitis, I can go for the ERCP.
Okay. If you fail to manage this patient, what are the complications that you should look out for that can take place or occur?
Okay, if we fail to manage this patient, then there might be pseudocysts, there could be hemorrhagic pancreatitis, there could be a multi-organ failure, there could be systemic inflammatory response syndrome, there could be adult respiratory distress syndrome. These would be the major complication along with the hypovolemic shock, and other complication could be the abscess, ascites.
Can you please tell me what or how would you take care of the nutritional status of the patient?
I will check if there is mild pancreatitis. I will check the Glasgow criteria and will see if it is mild pancreatitis or severe. If it would be mild pancreatitis, I will start with the enteral nutrition, nasogeneal or nasogastric feeding. Or if it would be severe pancreatitis, I will start with the total parenteral nutrition and involve the dietitian in the care.
Okay, what is the criteria to determine the severity of the pancreatitis? Can you name few, please?
Okay, yeah, there are the 3 or 4 criteria which is used to classify pancreatitis, and the main is Glasgow criteria, and then there is Benson criteria, then there is Apache 2 score, which is acute physiological assessment and chronic health evaluation. And there is Val hazard CT scan scoring system. There is Atlanta classification, which is also used.
Can you please tell me about the Renson criteria on admission and after 48 hours? How is it different?
Okay. Okay. On admission, there would be glucose level greater than 11 millimole per liter.
Yes.
And there would be I will also see if your age is greater than 55 years,
yes.
And if there is lactate hydrogenase greater than 350 international unit per liter, and AST level greater than 250 international units, and
yes.
I will also see the neutrophil count is greater than 16,000.
And after 48 hours, how it would be different?
After 48 hours, there would be fluid sequestration greater than 6 liters. There would be base deficit greater than positive 4.
Yes.
And there could be one BUN level greater than 1.98 milliwatt per liter. And after 48 hours, there would be partial pressure of oxygen less than 8 kilopascal.
Yes.
And I will
low calcium.
Yeah, so hypocalcemia level less than 2 millimole per liter.
Can you please tell me, in order to confirm your diagnosis, which blood test is confirmatory or is considered confirmatory?
For this patient,
yes, please.
Serum test for this patient, serum lipase would be more specific in comparison to serum amylase. And then there,
do you think serum amylase is an important marker for the scoring system to consider?
No, it is not that
okay,
important.
Good. Can you please tell me 2 situations in which even when there is acute pancreatitis, but the serum amylase level would be normal?
In early pancreatitis or after 48 hours?
Or in the late, okay. Can you please tell me, would you or would you not consider giving antibiotic to this patient?
I will consider giving antibiotics for this
according
patient.
To the NHS protocol, yes.
After discussion with the microbiologist and after looking at the BMS.
Very good. Very good. Excellent. Excellent. Good. Started the timer and here is your question. Okay, now if you have read and understood, considering it communication skills station, kindly begin.
Hello, my name is Dr. Mamoon, and I'm one of the exam candidates. May I confirm your name and age, please?
Yes, I'm Mr. Jack. I am 40 years old.
Nice to meet you, Mr. Job. Today I've been asked to talk with you regarding an investigation. So we would like to arrange with you. So could you tell me what you know so far about this investigation?
Okay, good.
Actually, I have no idea about this. Can you tell me?
Okay, Mr. Job, this is a Sepago gastroduodenoscopy, and the abbreviated form is OGD, and the camera is called endoscope, and this will insert it through your mouth into your food pipe, then stomach, and then into the first part of your small bowel, and it will rely on image and TV screen. We can look inside, and we may also make widening of your delivering part, which was previously discovered with barium images, and we are make a sample from your from the lining of your food pipe. So, are you understand, Mr. John?
Just don't. What do you mean by barium? Don't know that.
Yes, barium is the another alternative option. During this investigation, you have to drink a solution of contrast, and it will be followed by series of X-ray. So this is one kind of investigation.
So, is it painful, doctor?
So there, I can appreciate that, Mr. Jack. There are two options: local anesthesia, or you can be sedated. During local anesthesia, there will be spray into your throat to numb the area, and but the benefits of local anesthesia are you can go straight to your home, and also you can drive for next 24 hours. So, but you should avoid hard drinking for next 30 into 60 minutes. And if you receive general anesthesia, so you should stay in the hospital for the next few hours, and there should be someone to accompany you, and you cannot drive for the next 24 hours. Are you understand, Mr. Jake, this for you?
Oh, so will I feel pain or that's?
No, if it is, yes, as I told you, say if you receive general anesthesia, there will be no pain.
Okay. So, is there any risk that could be happening to me? Any adverse outcome?
Mr. Dick, this is a nice question. So no procedure is without risk. So the possible risks are trauma to your teeth when you be inserting the scope, and there will be also chances of the chest infection, bleeding from the tissue side. And the most danger one is there will be cut through of your food pipe, which may require surgical repair.
Oh, I don't need this investigation. I don't want it.
So I appreciate your concern, Mr. J. So a listing of these risk factors, it doesn't mean it will all occur essentially. So my advice for you is you should accept in the performing of this investigation, because it will help a lot about figuring out of your condition. So I'd like to make sure you only skillful experienced surgeons are allowed to perform this procedure. Is it a good sound?
Good.
Okay, doctor. I just have a little more concern. I keep salivating. I don't know what's the cause of that. Yeah.
So this is another good question from your side, Mr. Jake. So it is due to nearing part inside your food pipe. So it also hinder the normal salivation flow down to your stomach side.
Okay, doctor. Do you know what this could be? Is it a cancer or something else?
I appreciate your concern, Mr. Jake. It is too early to tell you it could be due to cancer. We should wait to the result of this investigation, and we may need perform further investigation.
Okay, doctor. So when the result of my sample will be appear?
Mr. Jake, so it will take around 2 weeks frame time. So once it's available, I will inform you and I will call you. Are you okay with this, Mr. Jake?
Okay, doctor. So have you seen my investigation? Can you tell me what's the result?
Yes, I have seen. So yes, I've seen your result of your investigation. So now is not I have no any proper investigation. There is no any clear result. Sorry. That's why we need to perform this investigation.
Okay, doctor. Thank you.
Do you have any other question?
No, doctor. Thank you.
People still have
Okay, Mr. Jake, I would like to summarize what we have been throughout. I would like to summarize what we have been throughout. We would like to arrange a OGD, and this, as I told you, it will help a lot to figure out your condition. It will be under sedation. I also listed all possible risk factors, and so if you agree with this, you should sign and then consent form.
Okay.
Okay, Mr. Jake, we are here to help you, support you. If you have any question,
one last question. If biopsy shows carcinoma, how would you manage it?
Could you please repeat me the question, madam?
If the biopsy shows carcinoma, how would you manage it?
So first of all, I would like to discuss this in the MDT. So it is if it is operable, then I will go for acipagectomy along with chemotherapy, radiotherapy. If it is not operable, then I will go for palliative care like passing passing some type of stains and self-expanding stains, and also palliative chemo and radiotherapy.
Okay. Yes, give the consent form and conclude your conversation. Yes.
Okay. Yes, Mr. Jake, we are here to help you, support you. If you have any question, you can call me anytime, and I will put my mobile number for you with the North Star. Thank you so much.
Okay, doctor. Thank you.
Good. Just for 3 seconds. Right. Yes. How does it feel? Can you give feedback first? I think it was good conversation.
It was a good communication.
Yeah.
Yeah. In the start, he forget to wash hands.
You forgot what?
Check hands. Wash hands.
Oh, wash hands. Okay. Yes.
Yeah.
But he presented
he asked me to confirm my name and age. I think in communications with patient or relative, you just have to call my name. So, for example, hello, Miss John. Hope you are doing right. Well, I'm fine.
Not in this case.
Not sure about the confirm.
Yeah, not in this one. I don't think so, because here patient is not already scheduled. It's not already on the list. This patient was already on the list, and he had to approach and cancel it, just like arthroscopy case. In that one, patient's name should be known to the candidate or to the doctor. But here, it's not the case, because here he's approaching and he has to confirm, because patient was sent by the GP. So if he asks the name and age, it's correct.
Okay.
Yes. Because patient was sent by the GP, and now
also he can yeah.
Yes, please continue.
Yes.
Yes.
Just to, one can draw on the paper just to demonstrate the OGD from the
Yeah, that he can add.
towel.
Yes,
Yeah.
good. This
I
he
think
can
this
add.
will be good.
Otherwise, yeah, otherwise
Yeah.
it was good. This he can add once, just suppose you're doing this in examination and you have this patient. So when you're explaining, you can draw a little drawing and you can explain how through food pipe, it's just the size of a small coin. It's introduced through food pipe and how it's going out. Like you can just draw a simple figure or simple diagram to explain it. This you can add in your routine of explanation. Otherwise, when you started explaining, you did it very well. Yeah, it went very well. And you explained even how, if it was painful, so how you can avoid the pain as well. You gave the options as well. So just drawing what Dr. Muhammad is saying, it's a very good alternative. It's a good way of explanation. Right, nice, excellent. I did feel that it was a nice communication between you two, and you attempted all the valid aspects of this station. It was just this one, because in exam, the patient will be a professional one. Patient will not miss out any question. So if patient will ask you the question which I asked at the end about the management, your answer was right, that you'll discuss it with MDT, and then you'll think of or take off with the management. And then at the end, conclusion was also right, that you explained everything and you asked the patient to sign the consent form, because that's how it should conclude. And the last sentence was also correct, concluding that you leave the number with the staff and you can be contacted anytime if any question arises. So it's good, nice, good. Thank you, both of you.
Thank you, madam.